So the biopsychosocial model is the most prevalent model of talking about pain and pain management is by saying that we should move away from it being purely biological, i.e. looking for a surgery or an injection or a medication. And we realized that there are conditions like anxiety and depression and PTSD, mental health conditions wherein the prevalence of pain, the incidence of pain, chronic pain in those patients with depression or anxiety can be as high as 60, 70%. But if you step back and you look at it there, and I tell you that pain itself is a protection experience, it is a decision of the brain to protect you, and that's when we'll bring about the experience of pain. Anxiety, depression, PTSD are also mental health conditions, and we are saying, but ultimately they are ways of the brain to protect. In anxiety, the brain is looking out because it doesn't know where danger is coming from. In depression, it feels the danger is so much that it tells it to withdraw because that way it is protective. And in PTSD, it has had a significant trauma that it realizes keep everything on high alert rather than taking a chance. So all of those are adaptations of the brain and the body to protect the person from future problems. That is what all these conditions are. So it is not surprising that there is a psychological element as well, that pain can be amplified if somebody is anxious or depressed. And vice versa, if there is excessive pain, they will feel anxious and more depressed because it is all one part of the nerve circuits in the brain. They are all mediated by the emotion processing center in the brain. Similarly, social things, if you are having loneliness, you have the COVID pandemic, you have a virus that you don't know where it's coming from, what it's doing, how can you get it, what can you do to protect yourself. There's no cure, there's no clear proof that the vaccine works in everyone. So you really have a challenge that when you have a social setup where you have loneliness, where you have threats from the environment that you cannot handle, where you may have a less than supportive manager, where you have a relationship that's breaking down and you are alone with no family support, where you are an immigrant or a refugee. These are all potentially social stressors which can also contribute to threat. Ultimately, threat is what the brain is going to manifest as an experience of pain. So that is how we are saying that pain is a psychological element, social element, and a biological element. I feel that we should be turning this whole thing around on its head and saying that pain should be considered as a socio-psychobiological thing, because by calling it a biopsychosocial, we've got treatments for bio, we have psychologists and physiotherapists and counselors for psychology, but for social, they are just getting left. We're just leaving it saying, okay, somebody will sort it out. But in clinical practice and as a pain clinic consultant, I have been noticing that a lot of times it is the social problems, loneliness, job loss, financial identity, the environment they are living in, the behaviors they are adopting is all due to what is called social determinants of health. And if you don't tackle the social determinants of health first or foremost, then whatever suggestions I give them, if I give a drug in the clinic and I'll say I'll see you in 3 months, if I give them an injection and I'll say in 3 months, and I tell them please eat well or sleep well or something, if I have not taken into account what their support systems are there in the community, then they will not be able to do anything. Because to sustain a behavior, to do a good, healthy lifestyle change, you need some kind of sustainability, you need some kind of support in the community to help reinforce what I have told them. And right now, that system isn't there. So I think the way to think about pain is a socio-psychobiological. We need to think about what kind of traumas, whether that is micro traumas like bullying or loneliness or isolation, and the major traumas, any road traffic accident, surgery, major illness, cancer. But all of those trauma informed approaches are important. And we have to build assets in the community. Nowadays, in primary care in the UK at least, and I think in many parts of the US, we have got extra workforce that is supporting the GPs in primary care, people like paramedics, health coaches, social prescribers, care coordinators, pharmacists. I think we need to bring all that workforce group to provide that understanding and that support to the patients, to use other community organizations and faith organizations and elders and other community support systems to buffer up the community, to give them all that whole health, lifestyle medicine based public health approach, and then come from the bottom up, support the community, create that supports there so that the pain that we give them an advice in secondary care can then be reinforced in primary care. So it's not only top down, but we need to come bottom up as well. And I think that is probably the best way to view pain and manage pain.
You're saying you reverse just the terminology. I understand because of the reason biological is there anyway, that most of the people or the doctors or everybody know, keep it as a last resort rather than the first.
It is. In some ways, most of the time, when you switch a word around, it breaks attention. And I'm going by this in almost marketing style. If you want to break somebody's thought process, you need to give it something slightly different. You need to break and you need to bring about attention. And that is where I am thinking of by just changing the word. And I know it's not that I made up this. It is something that we are talking about in the medical community to say that let's put socio-psychobiological first, because the moment you say that, people will look at the social first. And I think the social determinants of health need to be addressed. And that is where I think the word is coming along. And it's the same with the other word called nociception. You introduce a new word, people will say, okay, what is that word? Why is that word? So there'll be a little bit of curiosity because you have actually just broken pattern.
Sure.
And I think this pattern disruption by just using a different word or a different way of the word is what we are trying to do here.